Today, we're going to discuss some of the craziest surgeries that you have ever heard of, and also some that you may not have heard of either. And just for good measure, we are also going to talk about the riskiest, rarest, and the most dangerous surgeries as well. So buckle up as we blast through this list of procedures to see what we can glean about human anatomy and how we, as surgeons, deal with it when performing surgical techniques. And don't miss one of my personal favorites at the end that you probably won't even believe is possible. Please note that every procedure depicted in this video was performed or supervised by professionals, and each clip is carefully contextualized within a lesson on human anatomy, as per YouTube's community guidelines. Yes, I'm talking to you, assessor bro. I'm talking to you. Now, as you know, I'm an orthopedic surgeon. I perform both elective and emergency surgical cases anywhere from 2 to 5 times per week. When I am on call, I see patients who have been injured as a result of accidents, falls, or other trauma, and I perform urgent and emergent procedures to address the injuries that they have suffered. This includes ankle fractures, hip fractures, wrist fractures, and ruptures of tendons that include the quadriceps and patellar tendons and the distal biceps tendon. Although not an exhaustive list by any means, these are some of the more common emergency procedures that I perform. In each case, surgery is indicated by the injury at hand and is necessary since the injury is unlikely to heal properly or in a timely fashion without it. But the line between necessary and unnecessary becomes harder to determine when we are talking about elective surgery. Elective surgery refers to procedures that are performed at the request of a patient and at the discretion of the surgeon to address problems or subacute injuries that may arise. They are usually related to lifestyle or quality of life issues, and generally patients have failed non-operative treatments to address their issue.
Have you tried turning it off and on again?
In fact, typically a primary surgical indication is that they have failed all other conservative treatments before they have sought the advice of a surgeon. Just so you know that surgeons are not out here performing surgeries all willy-nilly and all.
Okay, here goes. Oh God!
That kill me?
That being said, let's get to it. Generally speaking, when surgery is performed by appropriately trained surgeons in a hospital setting for suitable indications, after a patient has exhausted and failed non-operative treatments, it is safe and effective with good to excellent results. In fact, the most common surgeries performed in Canada and the US include cesarean sections or C-sections and appendectomies, respectively. According to Johns Hopkins Medicine, a C-section is the surgical delivery of a baby by an incision through the mother's abdomen and uterus. This procedure is performed when doctors determine that vaginal delivery will be more dangerous for the mother, baby, or even both. The World Health Organization reports that globally C-sections account for 21% of all childbirths and that rates are rising, with up to 29% of all childbirths anticipated by C-section by the year 2030. In Canada, the Canadian Institute for Health Information data shows that the rate of C-section births is already 31.7%. I guess that means we're ahead of the curve. Johns Hopkins also describes an appendectomy as a surgical removal of the appendix, a small tube that branches off of the large intestine, to treat acute appendicitis, which is the acute inflammation of this tube due to infection. An appendectomy is the definitive treatment for appendicitis. The appendix is a small finger-shaped pouch of intestinal tissue which is located between the small intestine, or the cecum, and the large intestine, or the colon, in the lower right quadrant of the abdomen that branches off the first part of the large intestine. A blockage in the lining of the appendix is the likely cause of appendicitis. This blockage can cause an infection, which can lead to a rupture and the formation of an abscess. The National Institute of Health reports that appendectomy is among the most commonly performed surgeries in the United States and even globally. Appendectomy is a relatively safe procedure with a mortality rate ranging from 0.09% to 0.24%. But these C-sections and appendectomies are commonplace. One of the rarest surgeries, on the other hand, is the separation of conjoined twins. A 2017 review paper from Clinical Anatomy states, conjoined twins result from aberrant embryogenesis, the process where an embryo is formed from the sex cells of both parents. With conjoined twins, the embryo does not separate all the way and the twins remain connected. It occurs with an incidence of 1 in 50,000 births, but since 60% of cases are stillborn, the real incidence is about 1 in 200,000 births. Conjoined twins are classified based on the site of attachment, and the extent of organ sharing, particularly the heart, determines the possibility of a separation procedure and its likely prognosis or outcome. An article from the National Post recounts the story of Abby and Aaron Delaney, conjoined twins that were born by C-section in July 2016 and subsequently separated 1 year later by a team of doctors, nurses, and other medical personnel. The twins were craniopagus twins, or twins joined at the level of the cranium, which make up only 2 to 6% of all conjoined twins. The hospital where they were treated had separated 22 sets of twins over the past 60 years, but had never separated twins joined at the head. The team of 30 individuals worked for over 11 hours to successfully perform the uncoupling. During the procedure, the surgeons worked to untangle blood vessels and separate out the brain's outermost membrane, the dura mater, and the sagittal sinus, which helps to return blood back to the heart. After the initial procedure was completed, additional procedures were performed to replace missing bone on the top of their skulls and to work on their hairlines to make them appear more cosmetic. Only 4 months after their initial surgery, the twins could roll over onto their stomachs, sit up, and even start to crawl. And although their recoveries were not completely without complications, the twins gradually recovered and were discharged from the hospital, which is amazing considering that part of the separation procedure included performing a craniectomy on each of the twins, which is itself a very risky procedure. There are a number of procedures that have elevated risks, especially when performed in an emergent setting. A 2016 article from JAMA Surgery states that emergency general surgery, or EGS, represents 11% of surgical admissions and 50% of surgical mortality in the United States. 7 operative EGS procedures collectively accounted for 80% of procedures, 80.3% of deaths, 78.9% of complications, and 80.2% of inpatient costs nationwide. The list of these procedures includes partial colectomy, small bowel resection, cholecystectomy, operative management of peptic ulcer disease, lysis of peritoneal adhesions, appendectomy, and laparotomies. However, one of the riskiest surgeries that can be performed is the craniectomy. A craniectomy is a complex surgical procedure that involves removing a portion of the skull to relieve pressure on the brain. The life-saving procedure is usually performed on those with severe brain injuries with associated swelling and bleeding that is so severe that it could lead to brain compression and death. So already, you know that we are dealing with a compromised population. The Cleveland Clinic describes the steps involved in this procedure, which include shaving the surgical site, making an incision over the area where the craniectomy is required, using a drill to complete craniotomies, or drill holes that mark out the edges of the craniectomy, connecting the holes by cutting between them, removing the bone released to expose the treatment area. Of course, after the bone has been released, surgeons still have to treat the underlying problem that made the craniectomy necessary. And since swelling was one of the main reasons for the procedure in the first place, you simply can't replace the bone after the procedure. Usually, surgeons will cover the open part of the skull with a temporary mesh before closing the muscle and skin back over the surgical area. None of this sounds particularly easy or safe. A 2013 article from the Journal of Neurosurgery reports that the 30-day mortality rate associated with this procedure was 26.4% in traumatically brain-injured patients undergoing decompressive craniectomy, with the majority of deaths resulting from uncontrolled brain swelling and extensive brain infarction, which accounted for 79.2% of mortality. Not exactly a walk in the park. And if you do survive, there is the little problem of the bone flap that was removed from your skull and the divot left in its place. Typically, bone is stored in a sterile fashion in a medical freezer until that time at which it can be replaced back in the skull by a cranioplasty procedure. However, if a medical freezer is not available, the bone flap can be stored within the patient's own abdomen where the bone can remain sterile and viable for an extended period of time. And since you have nothing protecting your brain until the bone is replaced, you will have to wear a helmet to protect your brain from further injury while its protective covering is sitting inside your belly. And while this may sound strange, it isn't even one of the craziest surgical procedures. Trauma surgeon Dr. Hillsden, a friend of mine, posted a video about the craziest surgery that a trauma surgeon performs, a trauma thoracotomy. As the authors point out in the up-to-date article about this procedure, a resuscitative or trauma thoracotomy is a procedure of last resort that is performed only under specific clinical circumstances. It is almost exclusively performed in the emergency department, and if you require this procedure performed on yourself, you are in a very, very bad state. The procedure involves gaining rapid access to the heart and major thoracic vessels through an anterolateral chest incision to control exsanguinating hemorrhage or other life-threatening chest injuries caused by penetrating trauma. And this just means that you are bleeding really, really badly. And when you describe it that way, it makes it sound like it's just like any other surgical procedure. It is not. Dr. Hillsden describes it best.
The first step is to incise the chest. You take a large scalpel, you incise the skin from the sternum all the way down, as we say, to the bed.
Through a cascade of surgical steps, which include incising the chest, dividing the pericostals, placing the retractor, and incising the pericardium, the heart is delivered into the operative field and access to the aorta and vena cava are provided. And just let me take a moment here to reiterate something that you may have missed earlier. All of this occurs in the emergency department, not in a surgical suite after you have been prepped and rendered unconscious by anesthesia, but rather raw and at breakneck pace in the emerge as a trauma team races to bring you back from the verge of sudden death. As Dr. Hillsden mentions, when performing this procedure, getting the heart out of the compressive environment associated with bleeding is
the most helpful thing that you can do. If that helped the patient, that's great. If it didn't help the patient, now you're kind of in the quote unquote Hail Mary, lower yield return types of procedures that you'll do to help.
Cross-clamping the aorta, massaging the heart, or extending the thoracotomy to a clamshell thoracotomy are procedures that make a trauma surgeon really work for their money. Although there are several indications for an emergent thoracotomy, it is most indicated when
the penetrating trauma that is in the trauma bay, they have vital signs and they lose vital signs in the trauma bay. Well, this is the best case scenario,
which yields an overall 30-day survival rate of 32% for trauma patients who underwent either a resuscitative or emergency thoracotomy. Outcomes were better for penetrating trauma, 72% survival, than they were for blunt trauma, 23% survival. Meaning, it is probably better to be stabbed in the heart than it is for your chest to come to a very sudden stop against an immovable object. If you're interested in more great content about general surgery and trauma, then check out Dr. Hillsden's YouTube channel, Knife Skills, here on YouTube. But believe it or not, an emergent thoracotomy isn't even the strangest surgery. What about the osteoodontokeratoprosthesis, or OOKP? Often referred to as a tooth in eye surgery, this is a procedure where surgeons use a tooth to restore a patient's sight. What? I know what you're thinking because I'm thinking the same damn thing. Like, what the bloody hell are you talking about? The OOKP, first described in the early 1960s by Professor Benedetto Strampelli in Italy, is used for patients whose blindness is caused by irreversible damage to the cornea, the outer layer of the eye, and for whom other treatment methods have failed. The technical steps of this procedure involve the removal of a patient's canine or premolar tooth and the surrounding bone, drilling out the tooth, implanting a plastic lens into the tooth, and then implanting the lens tooth structure into the patient's cheek, where it grows new blood vessels over a few months. Eventually, this Frankenstein construct is then removed from the cheek and implanted into their eye. Light is able to travel through the lens, restoring the patient's vision. Come on, man. Who would ever think that something like this was possible, and why would they even do it? A 2018 article from the Journal of the Indian Prosthodontic Society describes this unusual nexus between dentistry and ophthalmology. The authors note that Strampelli had noted that gutta perca, the rigid, naturally biologically inert, resilient, electrically non-conductive, thermoplastic latex used in dentistry, could remain in root canals of the tooth indefinitely, but would be rejected if implanted into soft tissues. Strampelli surmised that if a plastic acrylic implant could be held in a piece of the patient's tooth and bone, and the whole piece placed in a corneal envelope, the tooth and the bone could form an autographed picture frame for the acrylic and so prevent its extrusion out of the eye. Like, who would have thought? I can imagine the conversation now.
You got a little more work done, huh?
Yeah, just a little bit, just tweaking. Maintenance.
Since the procedure's inception, the procedure has undergone several iterations that have improved both long-term visual and retention results. The current version is referred to as the Rome-Vienna procedure. And as weird as it seems, the Rome-Vienna protocol is the gold standard for this technique, used to address bilateral end-stage ocular surface disease that has repeatedly failed or cannot be managed with any other surgical reconstruction method. This procedure takes the term eye tooth to an all new level, but not ones to be outdone by ophthalmologists. Leave it to the orthopedic surgeons to come up with the strangest surgery that you have probably never heard of. So, what happens when you take someone's leg, cut it, rotate it 180 degrees, and then reattach it backwards? On purpose, bro. On purpose. Well, you get a Van Ness rotationplasty. So, what the heck is this madness of which I speak? A rotationplasty is an amazing type of reconstructive surgery that enables the ankle to be used as a knee joint. Yes, you heard what I said. The procedure involves the surgical amputation of the distal end of the femur, the knee, and the upper tibia. The lower part of the leg is then rotated 180 degrees and attached at the level of the thigh. In one sentence, the foot is attached to the knee backwards, man. Once a prosthesis is fitted, the ankle of the foot functions as a knee. Rotationplasty is most commonly performed in children who have malignant bone tumors near the knee, such as osteosarcoma or Ewing sarcoma, that have not responded to other treatments.
When I was 10 years old, I developed a bump underneath my left knee and it became pretty sore. Found out that it was osteogenic sarcoma, which is a type of bone cancer.
The main aim of rotationplasty is to completely resect the tumor, but in a way that allows a child to continue with an active lifestyle, which would be less likely with a complete above-knee amputation. Canadian Paralympic snowboarder John Leslie explains.
Strain amputation was heavily on my mind, but because sport had already been such a big part of my life, I went with a Van Ness rotation.
Cancer survivor Gabby Shull demonstrates how her prosthesis is applied.
So step one, I put on my sock, and then I just slide my foot into the prosthesis. And then I strap it up. And now whenever I point my foot, it straightens the prosthetic, and whenever I flex my foot, it bends the prosthesis.
Gabby's mother states that we learned that there is absolutely no cons to rotationplasty except the way it looks. And if you can get past that and focus on your quality of life, then you've gained everything and have lost nothing.
Everyone's in the same shoes, like everyone's got a hard story. If you're focused on, your problems, you're never gonna make it to the top.
Leave it to orthopedic surgeons to come up with something so completely wacky, but yet so damn functional.
That's outrageous. Done.
Talk about making lemonade out of lemons. So for 2024 interns, we're looking to increase the frequency of content creation. And so I am increasing the size of my team. If you want to help me hire new staff to add to the team, then feel free to sign up for a membership plan down below. And don't forget to follow my gym, Human 2.0 Fitness, for free right here on YouTube, where we post content that helps you move better and prevent injury. If you enjoyed the video, be sure to subscribe and give it a big thumbs up to feed the algorithm. If you didn't, be sure to let me know why in the comment section down below. Otherwise, as always, that's been a word from Dr. Chris, not your everyday ortho, where we see one, do one, teach one.